Topic is histopathological studies of some lymph node pathologies. Tubercular lymphadenitis histopathology. Related study. Tubercular lymphadenitis histopathology, non-Hodgkin's disease lymph nodes histopathology, and Hodgkin's lymphoma histopathology. Then secondary is to the lymph. First, tubercular lymphadenitis. The histopathological hallmark of tubercular lymphadenitis is necrotizing granulomatous inflammation, classically presenting with central caseous necrosis surrounded by epithelioid histiocytes, Langhans multinucleated giant cells, and a peripheral rim of lymphocytes. Histopathology remains one of the most reliable and highly sensitive diagnostic tools for confirming tuberculosis in tissue specimens. Key microscopic features. When examining a biopsy specimen stained with hematoxylin and eosin, a pathologist typically looks for a specific constellation of cellular features. Caseous necrosis. Located at the center of the granuloma, it appears as an amorphous granular structureless eosinophilic pink debris zone, devoid of identifiable cellular outlines or nuclei. Epithelioid histiocytes. These are modified, activated macrophages surrounding the necrotic core. They feature abundant pale pink cytoplasm with elongated oval or slipper-shaped nuclei closely resembling epithelial cells. Langhans giant cells, large multinucleated cells formed by the fusion of activated epithelioid macrophages. They are characteristically identified by their peripheral horseshoe shape or ring-like arrangement of nuclei. Lymphocytic ring, a dense outer collar of small, mature lymphocytes and plasma cells encapsulating the granulomatous complex. Fibrosis and calcification. Healing or chronic lesions may exhibit thick bands of peripheral collagenous fibrosis or dark purple dystrophic calcification deposits within the caseous zones. Histological disease spectrum. The cellular architecture of tubercular lymphadenitis can present as a fluid spectrum depending on the host's underlying immune status and the duration of the infection. Ancillary stains and conformation. Because other infectious and non-infectious conditions can cause granulomatous lymphadenitis, histopathological findings must be supplemented with specialized microbiological verification. Zeal-Nielsen stain, used to detect acid-fast bacilli. Under light microscope, Mycobacterium tuberculosis appears as slender, beaded, bright red or pink rods, typically located within the necrotizing zones or inside epithelial cells. Fluorescent microscopy. Stains like auramine, rhodamine can be applied to enhance bacillary visibility against a dark background, optimizing detection when bacillary load is low. Correlation. If a tissue specimen displays highly suggestive pathology but remains AFB negative under microscopy, clinical confirmation relies heavily on gene expert MTB or RIF, molecular assays, or microbacterial tissue cultures. Another slide of tubercular lymphadenitis. Next is non-Hodgkin's lymphoma. Diagnosing non-Hodgkin's lymphoma requires a tissue biopsy of an affected lymph zone examined by a pathologist. Histopathology assesses the growth pattern, nodular or follicular or diffuse, and cytology, cell size, shape, and nuclear features. This is paired with immunohistochemistry to identify specific cell surface antigens and determine the exact NHL subtype. Key histopathological patterns and subtypes. Follicular lymphoma, characterized by a nodular or follicular growth pattern, where normal lymph node architecture is replaced by uniform, tightly packed neoplastic follicles. Cells are typically small cleaved lymphocytes, centrocytes, mixed with larger non-cleaved cells, centroblasts. Diffuse large B-cell lymphoma shows a diffuse growth pattern where normal architecture is completely effaced by sheets of large atypical lymphocytes with large nuclei, dominant nucleoli. Burkitt lymphoma presents a diffuse monomorphic infiltrate of medium-sized cells. A classic starry sky appearance is created by scattered benign macrophages containing engulfed cellular debris, fungible bodies. Mantle cell lymphoma exhibits a mantle zone, nodular or diffuse pattern composed of small to medium-sized lymphoid cells with slightly irregular or notched nuclei. The non-Hodgkin's lymphoma. Next is Hodgkin's lymphoma. Hodgkin's lymphoma histopathology is defined by the effacement of the lymph node architecture and the presence of rare malignant Reed-Sternberg cells scattered within a dense reactive background of non-neoplastic inflammatory cells, for example, T cells, eosinophils, plasma cells. Key histologic features. Reed-Sternberg cells, a diagnostic hallmark. These are these are giant multinucleated cells or bilobed or multilobed with prominent eosinophilic all-eye nucleoli and ample cytoplasm. Variants include mononuclear Hodgkin cells and Lankinov cells. Immunohistochemistry. Reed Sternberg cells typically test positive for CD30 and CD15, but are characteristically negative for CD45, leukocyte common antigen, and often CD20. Reactive background. The specific composition of surrounding inflammatory cells dictates the disease subtype. Classical Hodgkin's lymphoma subtypes. Nodular sclerosis, most common, characterized by dense collagen bands dividing the lymph node into nodules and the presence of lacunar cells, RS cell variants that shrink and leave clear spaces during tissue processing. Mixed cellularity features a polymorphous background rich in eosinophils, macrophages, plasma cells, and classic D-stagnant cells, strongly linked to Epstein-Barr virus. Lymphocyte range. Abundant small lymphocytes obscure the RS cells, which can make identification tricky. Lymphocyte depletion arrest features a paucity of lymphocytes and an abundance of bizarre RS cells or diffuse fibrosis. Nodular lymphocyte. Predominant Hodgkin's lymphoma. This is a distinct non-classical variant. It lacks classical RS cells and is instead characterized by popcorn cells, lymphocytic and histiocytic cells. The cells are CD20 positive and CD30, CD15 negative. This is a Hodgkin's law. Next, last, secondaries in lymph. Secondaries or metastasis in lymph nodes occur when cancer cells break away from a primary tumor, travel through the lymphatic system, and begin growing in a new location. In histopathology, they are typically identified by the presence of a foreign cohesive cells nest, glands, or atypical nuclei within the node's native lymphoid tissue. Histological features and growth patterns. When examining a lymph node for secondary deposits, pathologists look for specific architectural and cellular changes. Sinus involvement. Metastatic tumor cells frequently enter the lymph node through the subscapular sinus first, subsequently spreading into the cortical and medullary sinuses. Nesting and architecture. Unlike native lymphocytes, carcinomas and melanomas tend to grow in cohesive nests, sheets, or glandular formations. Pathological atypia. The secondary cells will show distinct malignant features such as increased nuclear to cytoplasmic ratios, nuclear pleomorphism, hypochromasia, dark staining nuclei, and frequent mitotic figures. Extranodal extension. Pathologists evaluate if the tumor deposit has broken through the lymph node's fibrous capsule and is invading the surrounding nodal fatty tissue. Extranodal extension is a critical prognostic factor, often associated with a higher risk of local recurrence. The secondaries and the lymph. Another picture, secondaries. So today we have discussed the histopathology of four things. One, tubercular lymphadenopathy or lymphadenitis. And one is non-Hodgkin's lymphoma. Third one is Hodgkin's lymphoma. And fourth one is secondary is lymph nodes. Thank you for patient.